We want to say thank you for listening. So our sponsors have given some great deals in this episode. Check these out. This episode of the Real ResQ podcast is brought to you by Breeze Eastern, the world's only dedicated helicopter hoist and winch provider. Axness, because when lives are at stake and conditions are challenging, clear communication is of the utmost importance. And SR3 Rescue Concepts, because you don't know what you don't know. Breeze Eastern, they dedicate themselves to our helicopter rescue world. Since the very first helicopter rescue in November of 1945, Breeze Eastern has designed and manufactured superior rescue hoist solutions. While much of the technology and the unique mission requirements have changed over the past 75 years, their commitment to the rescuers, the operators, and those being rescued has not. Contact them today by visiting them at breeze-eastern.com. The Axness PNG wireless ICS system can bring cutting-edge wireless intercommunication system technology to any aircraft. The PNG system can be fully integrated into an existing ICS system or can be carried on and off as a mobile base station. They can go anywhere at any time on any aircraft. Plus, with the strongest and most robust waterproofed handheld in the market, this system can take a hit and keep working. Their wireless intercom systems are designed to enhance situational awareness through improved communication capability. This system brings superior noise canceling technology to eliminate rotor wash and engine noise from your ICS. The Axness PNG wireless system is currently deployed in more than 1,800 public safety, air ambulance, and search and rescue aircrafts worldwide. I have personally used the Axness system in 4 different countries and on 5 different airframes. It is awesome. If you want more information, contact them today at axness.com. That's AXNES.com. You just make sure you tell them Quinny sent me. And SR3 ResQ Concepts is a training company that can help with your helicopter training, a standardization and safety check, or maybe just an audit or an FAA refresher. They are here to bring your agency up to date with the most current techniques, rules, regulations, and equipment. The training staff is awesome. With a certified flight instructor pilots, experienced crew members, which I am happy to say that I am one of them, they offer training in rescue, medical, tactical, firefighting, ground operations, and night vision goggle use. SR3 is also partnered with Petzl to assist with personal protective equipment and the highly specific Lazard. SR3 also goes beyond the helicopter world as they provide high-angle rescue training and tactical medicine training. Contact them today at sr3rescueconcepts.com or over on Instagram at SR3_rescue. Up next, we've got another first coming to us. Not just any first, but a doctor. And not just any doctor, but a medical director. You know, the guy that signs the protocol to make sure we're all doing what we're supposed to be doing? Yeah, he's coming on. He's coming on to give some of his stories, his advice, and what he's had hands-on with. It's amazing. So please welcome our next guest, Dr. Chris Hewitt. My name is Jason Quinn. I am United States Coast Guard Rescue Swimmer number 500. These are my rescues and rescues from those of us that put our lives on the line every day so others may live. This is the Real ResQ podcast. Ladies and gentlemen, welcome back to the Real ResQ podcast. Today, I've got with me Mr. Even better, Dr. Chris Hewitt, emergency medical, pre-hospital medicine, straight up badass. What's up, Chris? How are you?
Good, Jason. How you doing?
Dude, I'm awesome. Thank you so much for coming on. I'm actually really looking forward to this conversation because you guys, we've been back and forth a little bit with a couple things, and now I get to finally hear everything throughout the entirety. So I'm excited. So
yeah, me too. Definitely.
Awesome. Well, I'll tell you what, man, if you don't mind, start us off a little bit, a little background about like who you are, and how you got into emergency medicine. More importantly, how you became a doctor.
The old story, like I like taking care of people. I don't know. I was always led towards medicine in a way. I was fascinated by the body. I was fascinated by what I could do, helping people to figure out how they could feel better, how they could perform better, how they could get better, whatever it was. It was always just something that always interested me, and I was always good at talking to people, and I think that's a big piece of what you have to be able to do to really be good at the clinical practice of medicine. So it was something that I felt like I was just kind of meant for, led to, one of those really cool things that, I got lucky and managed to survive college and get grades good enough that got me into med school.
Nice.
So I think the pieces started to connect for me as I was pursuing the idea of going to medical school, or actually when I started looking at colleges and getting ready to go to college. I was looking at the military, and they told me, you can go to med school, or you can go to college and you can go to med school, and we'll help pay for it. And I always thought the military was a cool way to do that, or just something that I felt in a way like something that I wanted to do. So those pieces started to connect, and then I joined the military in August of 2001, and I was actually in uniform for one of the first times on campus on September 11th, 2001.
Oh, wow.
Yeah,
that's
so
kind of a big day.
Yeah. So I was new to the uniform. I had no idea what anything meant, and then I felt like I was really kind of drawn to the idea of doing something for that, which leads into how I ended up in search and rescue. So as part of the response, if people don't know, I mean, the story of 9/11 is so big, but as part of the response, there's a guard unit of pararescue jumpers and search and rescue on Long Island, just outside of Manhattan. As part of that, of the mission to recover people from the rubble, the PJs who are trained in technical rescue and confined space and all that went as part of the teams. The aircraft went as part of the evacuation plans, and so they spun up this whole thing, and it's so incredible. I mean, like, you have people who do that for a regular job, and then you have people who do that kind of as a they're reservists, right? So their real job, their everyday job, they're cops, they're doctors, they're medics on some other place, they're pilots for airlines. They do all this stuff, and then they just hopped in and started doing it, right? So I thought that was really cool, and I thought it was something interesting, like a group that I really wanted to get to know more about. And that kind of led me, after going to medical school in New York, where I was even more so connected to all of that. It led me to pursue getting into search and rescue and to support that mission. And so my first active duty assignment after finishing a 1-year internship was in Tucson, Arizona, as part of the search and rescue unit there. And so I got to do desert rescue, mountain, high angle, all that cool stuff, and be the medical director for 60 special operations paramedics who were going out and doing all kinds of jobs that I wasn't even allowed to be told about sometimes. So
love it.
So some really cool stuff. So there's the story. I wanted to be a doctor, and somehow I wound up in search and rescue, and then I couldn't get out of it. After Arizona, I went to England, did it in England for 3 years, deployed 3 times over the course of 6 years with search and rescue. And then did my emergency medicine residency. And then I just enjoyed being a medical director so much, and I wanted to do it the right way. So I did a fellowship in EMS and disaster medicine so that I could help to really connect all the pieces, while doing a master's in emergency management and homeland security. So
yeah, because why wouldn't you want an entire full plate and then add more? Awesome.
Right. Yeah. I wanted to be able to support the mission and do it the right way. Like, the more the better you are, and the better you can support the guys that, like, as a med director, my job is at times to do medicine, but at times it's to support medicine. And so I have to know how to do it the best way. And we can get into that later. So
that's pretty good. So you went to school to actually, like, learn this stuff. Instead of, like, getting thrown into the blades, which you did as well, but hey, at least you got a little knowledge, going into it.
Right. Yep. Yep.
So
I learned what I didn't know also. So that's what led me there.
Awesome. You don't know what you don't know until you learn it.
Yeah. Yep. So you're under the blades, like you said.
Yeah.
Yep.
So you basically had no life minus school. No, I'm just kidding.
I mean, I'm trying to get there. At some point, I feel like I'll finally be done with school, and I can actually start doing the things I want to do. But retirement's still a little ways away. So that's about the time I'll get there.
Yeah. Well, you know what? I mean, you started in Arizona, you were in New York, you bounced over to England for a while. Now you're in the UAE. I mean, you're all over the place. So, I think you're doing all right so far. That's good.
Yeah, good.
All right. So you get through school, and did you go right into an ER and the reason I'm asking this is because I'm looking for kind of that very first rescue save. Again, you're the doctor, so you're I drop the patients off to you.
Mm-hmm. Yeah. So I mean, if you're looking for my first rescue save, I'll get there. But so after medical school, you do an internship. That internship kind of like prepares you. It's like kind of being indoctrinated as a doctor, right? Like you're kind of going through everything. You're learning how the hospital works that you've been training in for 4 years, but you're learning now as the decision maker how that works, right? And I think that, it's kind of similar to those first years as a junior paramedic, where you're you're able to make the decisions that they would train you to do, but you don't have enough experience yet to do it all on your own. So a lot of times it's nice when you have somebody there with you. Sometimes it doesn't happen, sometimes it does. But yeah, so I did my internship in a kind of a rural hospital where we got to do everything. And so I took care of everybody, and it was great. And I felt like there were times in that assignment that I had some really important saves, where I picked up on something, or where I made a decision for somebody, or where I pushed when everybody else was kind of stepping back, and I pushed, and I helped to make sure the right treatment was done. So I really enjoyed those saves. But I'd say if you want my first rescue save story, it leads from medical direction. It's still really close to my heart, because even though I wasn't the one touching the patient, I was the one who changed the way that the medic did his procedure, and that is what saved the patient. So so my first assignment in Tucson, I got there and I was like, hey, let me know how I can help. And they're like, hey, we're going to be running some night scenarios. We're going to, do some, we'll call it live tissue training, but we're going to learn how to take care of combat wounds out in the desert at night. We're going to do prolonged care overnight. We're going to have, we're going to figure out a way to set up some shelter, and we're going to run this. And so we were, before I start, let me just say,
okay.
So I should caveat before we get any further. I am a member of the U.S. military. What I say is my opinion, and my opinion only. It does not represent the U.S. military. Okay.
Wow.
So going back to the story.
Well done. Yeah.
Yes.
All right. Yeah, we just checked that box.
Check. I'm safe now.
All the public affairs are going to be so happy now. They're going to be like, oh, thank God. All right.
I know. I'll show up somewhere and they'll be like, you didn't say it. Like, no. Fast forward to whatever is in there. I haven't said anything about the military yet, so that's good. I've got to that point. All right. So first, one of my first military exercises where I was really connected to it, and I had to say that because the way that we did training, the way that the let's say models that we used and things like that were to as close as possible simulate a battlefield casualty and the complex scenario challenges that you would go through in a field scenario with real physiology, and that's as far as I will take that. Our scenario was kind of a blast scenario. We had multiple patients. One of those patients had a significant facial injury, and basically we made it too challenging to manage an airway. And so at night in the middle of the desert, I have these guys, young medics, very new, get dropped off by a helicopter, dust everywhere, can barely see. And like you said, under the blades, and you've got these patients that are all kind of already starting to circle the drain, and they needed to go through stepwise quickly what we would call what our March assessment, like ABCs, but we start with massive hemorrhage, right? So they get to airway, and I'm guiding the medic on this one patient, and needed to do a crike. And so he's trying to do a crike at night using green light, dirt everywhere. He's one of his first times ever really like busting into his kit, which is the wrong way to do it. But one of the first times going through, so he drops the scalpel, he loses this, he picks this, and so like all of this is just taking time. And so finally he starts to cut, and I see him like shaking. So I move his arm and I set him down. I put his hand so that he's not like hovering and, doing all the weird cocking motion, and like showing him just how to stabilize himself so he doesn't have to shake anymore. So then after he does that, he's like cutting, and then he's trying to use his hook and do all the other fancy stuff that they teach you in the schoolhouse, but is not the way that it ever is going to happen. So I just took his finger and stuck it in the hole. And I was like, put your finger there and you're never going to lose it, right? Like, what that feels like now. So he put his finger there, he could feel, he knew what the cricothyroid membrane and the area between the cricoid cartilage and the thyroid cartilage felt like. He could feel those things, and he could keep his finger in there, and then he could get the tube in there after he did that. Right. So I walk him through this. We actually kept the patient alive. We kept him alive for a good amount of the night. We went through a ton more. Afterwards in our debrief, I asked him to walk me through that procedure again, how he's going to do it. So he walked everybody through the procedure. So fast forward 6 months, we deployed to Afghanistan. I'm on alert. I happened to, at the time, be not flying. So I was 24 on, 24 on. I was either 24 on flying, or I was 24 on for rotary alert. So I was either fixed wing critical care transport, or I was rotary alert. And so rotary alert also meant that I was in the clinic most of the time. We get a call.
Of course.
They have I can't remember, what country. I actually won't say what country, but another country's vehicle had been blown up. They had people inside that they wanted taken out. And so they were going to go and do a recovery. They got onto the scene, didn't feel right. Things were kind of a little bit weird. And there was an explosion, a secondary. So it was a command detonation, actually took out a U.S. military explosive ordnance device, or EOD guy. And so, one of the guys who goes out and looks for the explosives, took him out, went straight up from underneath him. So he got kind of predatored. And so needed a crike. Yeah. So the first medic on realized that he needed a crike. He's struggling with this crike, and he's a senior medic. My junior medic shows up, does the exact same thing I did to him, gets the crike. That crike saved the dude. He actually kept that crike all the way back to the US. So from Afghanistan to Germany to the US, he kept the same crike because it was in so well, which usually it gets converted because it's bad, right? So because he did it right the first time, because he knew how to do that at night, in the dark, under stress, after people had just been blown up, they're worried about more people shooting at him, and he was able to do that. We got that U.S. member back, and he was Facebook friends with that medic within 6 months, and he's back to regular life. The most incredible feeling. Like I'm getting the chills now, and it's crazy because I didn't do it. Right? Like I didn't do it.
Yeah.
But that's the cool thing that we get to do as med directors, right? Like you get excited because you think about those times that you were out there and you actually did something that saved somebody. Man, like I might at times have several hundred medics that might do that on a daily basis. Like it's incredible, right? Like I could set them up for that. So
dude, that's sick.
And so yeah. So
God,
that one definitely like that one's close to my heart because you don't have that opportunity, and you don't see that. And as a young medical director at the time, like to have that experience, there's no going back, right? Like I was in there, like nobody could convince me to do anything else. Like that was what I was going to do forever. So, yeah.
Wow. Oh, Chris, that is awesome. Oh, I love it. You know what? I like there's so many avenues we could go out of that. Like what real life training, how real do you want the training to be in order to like perform the best you can when it actually happens? And
Yeah.
that's what we talk about all the time. Oh,
Yeah.
Chris.
I mean, if you want to talk about that, like I did that to a patient or to in a scenario the other day in the hospital, right? Like, you know, if you just run a scenario so that people run their checklist, right? Like, you know, when it comes to anything, especially trauma, right? Like we're just running checklists. Everything's algorithmic. You know, you can do your resuscitation and you can get a little fancy with it, but at the end of the day, it's very algorithmic. You have a life threat, you have a treatment, you put the two together every time. Like everything should just fall into place. But your patient doesn't know that, and they do everything they can to screw you up as you're trying to stay in your checklist, right? And so I like to do that to people, and it's annoying until you actually have to do it, right? Until you actually are in the position of having to deal with a patient who keeps trying to screw you up while you're trying to save them, right? They're trying to die, you're trying to save them, and they just keep screwing it up, right? So I like to do that.
They're
right?
trying
to
die, and you're trying to save them.
Like, you don't have to do anything crazy. You don't have to like, I don't abide by the like spraying, you know, people or like doing annoying things, but the patients don't lay still. So I'll take mannequins and just like roll them on their side, move their arms, you know, pull things off, like sit them up, like they don't just lay there and say, I'm a trauma, you know, do what you want to me. Right. Like, so that's why we make training, and I mean, I learned that early on, right? Like I would smoke my dudes, or I wouldn't do it. I mean, I tried to always be able to keep up with them physically, so that if we had to do something, I could keep up with them, and they knew that I was part of it. You know, like I wasn't just sitting there watching them like, I'm just the doc, I don't have to do this. So I would try and keep up with them, so that I was also like them. I was amped up. And it made it so that the scenario was that more realistic. But you know, like we would run them through some crazy workout, and then they'd have a med scenario, right? So now you're physically and mentally in a way already, you know, on like going into your red zone. And then now I'm adding these stressors of I'm asking you questions while you're supposed to be doing something, while, you know, so yeah, it's just, you know, we love running the training so that people learn how to perform under stress. And if you just stress people by like making them feel bad, that's not effective, right? Like you need to stress people for performance, right? Like my goal is to optimize your performance. It's not to break you down and make you question everything you do every time that you're in a bad situation, right? Because no situation is ever good when we show up, right? So I shouldn't make you feel bad about like, you know, like not knowing exactly what to do. I want you to be able to clear your mind when you're amped up and when everything's going and you've got adrenaline and you've got like people yelling and you've got somebody like asking you questions. I want you to be able to think, get yourself straight as quickly as possible, make decisions about the patient in front of you, and at the same time know what needs to happen as far as how you're going to get them out, how you're going to, you know, like all the other things. That all falls into place afterwards. But you can't do that if as a medical director and as senior medics. So for senior medics out there, this is your job too, right? Like you should not make people feel bad because they don't know what to do. You should do everything that you can to help to teach them how to make the right decisions. Right. Yeah. And that's the key. That's the key in all emergency care, is making the right decision. So, and not to say, not even the right decision, making a decision that's heading towards right. That's what I tell people all the time. You just need to head towards right. You do not have to, like, this is not a test. It's not ABCD, right? This is a linear, like A is heading towards B, and then once we get past B, we'll go to C, right? Like all of those questions could be the right answer. It's just leading along the way, right? So head towards right and just make decisions, because otherwise you're just going to be standing there doing nothing, and everybody's going to keep yelling at you, and the rotors are going to keep spinning, and pilots are going to get pissed, and somebody's going to want to go to lunch, and then, you know, all right. So like all those things happen. So, so yeah, that's my take on how to get people ready to make those types of decisions, and how to optimally perform in that type of environment. And it was going back to that case. Like, I mean, I did not make him feel bad because he dropped his scalpel. I did not yell at him because he wasn't doing things right. I changed his thought process when I grabbed something and I made him just get his hands and get control of the situation, right? Rather than floundering around and thinking, what am I supposed to do with my hands? Just take your hands and put them in a place and get yourself moving in a direction, right? Like steady everything. And then just do something, right? Like start doing something that you know is close to right, and just do it. And by doing that, it changed the way that he did it. And then by making him rehash how he did it after the fact, it solidified it to the point that when his life was on the line, his patient's life was on the line, he was able to save that dude and I mean, like, just crush it. And I mean, he got all the credit for it, and it's amazing. You know, he kept trying to pull me into it, and I just kept stepping back. Like, man, you were the one with the scalpel. You did it. So,
man, oh, I love that. I love where you're going with that too. Just make a decision. Make a decision. The other part about it, all right, so I'm going to dive into a little more training too, because I love the idea of making not things hard in training, but actually make them hard. You know, where you're, and again, my buddy Ashton said it, and you know, he's a pararescue guy as well. Is take that tactical pause. Boom. Take a minute. Take a breath. Look at it.
Yeah.
Tactical pause, and then proceed. Make a decision. It doesn't have to be you might not make the right decision, but at least you've made a decision, and then you can change it as things progress. Like, oh, I shouldn't have turned left. I should have turned right. Hey, whatever.
Yep.
Oh my gosh.
So I love
Chris,
the tactical pause. So take the tactical pause, right? Like, and this is something that I actually brought to residency. And I mean, working in special operations, some of the most incredible human performance people. And so this is one of the things that I brought to a lot of the young doctors that I was working with, right? Because I mean, you know, I went through residency 6 years into my military career. So I had already been doing all these things, right? Like I had been the one out there doing this training. I deployed multiple times. I had a lot of stuff, right? So I had grown up a lot. And so I'm working with a bunch of much smarter than me when it comes to the answers doctors, right? So they just came out of med school. They knew all the answers to the test. They were spun up on all the newest things. Like they knew the answer. They didn't know how to get there all the time, right? So taking that tactical pause was so helpful. And when I talk about the tactical pause, I connect it to a tactical breath, right? So that tactical pause, when you take it, you mentally, if you forcefully exhale and then deep breath in, and then as you slowly exhale, it just feels like you just clear, right? I mean, like if you do it over and over again, that's a real great way to kind of slow yourself down. It's called breathing the box, and you can look that up. Like they teach it to snipe. That's the sniper breathing technique, and you know, everybody uses that. But if you just take that forceful exhale, a nice long inhale, and then slowly exhale, that forces that's that tactical pause. It gives you the time to kind of like regroup, and you're focusing yourself and you're focusing your breath, and in a way focusing your physiology so that you can better perform from that point, right? So it gives you just that second. So when the tactical pause happens, you shouldn't have to think about it, right? You just quickly exhale, forcefully exhale, big breath. And then as you're slowly letting out, this is where it's like, okay, here's my decision, right? Here's where we're going. First thing this, second thing that, and then now you've slowed down, right? Like now everything's ready. Now you're ready to perform, and now you can kind of move into everything. But if you just like, you can barely breathe and you're taking these short breaths and you're constantly filling up and you're just like, everything is just going to stay so amped up. And so tactical pause, I love it, but tactical pause with a tactical breath.
Oh, we just went up a level. I'm loving it. Ashton, go teach somebody else. Chris, that's awesome. Yep. All right, man. Well, let's go into the next one, because you have an interesting rescue of a couple kids and some stuff, and kind of stuck to you. So I'm interested to hear about that.
So this came pretty late in my fellowship. We rotated through several places. I did my fellowship in Texas. So this is EMS and disaster medicine, but you know, the EMS experience, we rotated through several major cities in the US, including Houston. So we were primarily in San Antonio, massive, you know, 2 million person city, huge fire-based EMS system, great way to learn to be a medical director. And then we went down to Houston, 6 million people in the city, just covered in, crazy medical calls. I mean, just calls, all kinds of emergency calls all day long, everywhere. And so great experience for me there, especially because I was kind of a standalone medical director. And so we were the go-to 24/7. And so the call that I got, this call came towards the tail end of my last month down there, actually. And I was at the end of the day. I had already kind of I had settled in. I thought I was gonna, I thought I was done. I'd taken off like my polo and my tack pants. I'd thrown them in the wash. And this service that we worked with had wore video body cams, and we had like real-time access to dispatch calls. And then as soon as we could see the dispatch, we could see the call as soon as it came in. We could see it pop up, and then as it got updated and as units got assigned, we could see all of that real time on our phones. And then once we knew who was assigned, I could actually patch in to their camera on their body and hear them and watch as they're pre-briefing on their way to the call. And then once they arrive to the call.
Holy cow.
So
that's like next level stuff right there. That's awesome.
It's amazing, man. I mean, it is the body worn camera thing. I mean, like that's a whole nother podcast if you want to go into that, because I mean, I could tell you all the benefits to it, because it's incredible. And there's a lot of people who a lot of medics, I'll say, who are scared of the use, and they shouldn't be. But let's do that another time.
Okay.
So anyway, I see this I can't remember how they put it in, but like motor vehicle collision, multiple patients, and then it changes to multiple pediatric patients. So I was like, okay, like not good, right? When they, and usually like it could be bad, it could be, you have no idea, right? Like you're just reading the words. So then, and then I see multiple ejection, and I was like, that's not good, right? And so I patch into the medic's camera, and I have them up, and I start getting dressed, because I was like, this just has I have that feeling. So I throw on, luckily, another pair of tack pants, my tack pants, and wasn't even like my uniform polo. I just threw on like another shirt that I had, because I only had at the time one uniform polo. So
and it's in the wash at the moment. So
and it's in the wash. Yeah, it's I didn't come back. I didn't want to show up like soaking wet. That would look weird. So so I start tracking, and I'm planning on getting in my response vehicle and heading out. But I want to see what's happening before I get in the car, because I still have to drive emergency, and lights and sirens make people do stupid stuff. So I wanted to make sure that I knew what I was going to, and that I wasn't distracted while I was doing it. So I waited for a few minutes. I got in my vehicle. I see the medic show up. I knew her. I had actually just done a critical care course with her. And so she was very motivated. She was really solid. She shows up. She goes and does her triage. She did amazing. She walks through. She sees 3 patients outside of the vehicle and 2 in the vehicle. She goes and checks the driver, who was already agonal. And so she kind of presume that to be, at that point, an expectant. There was a kid in the driver's side vehicle, should not have been there, but a kid in the driver's side vehicle, or driver's side seat, or passenger side seat, passenger side seat. She was kind of pinned in, just because of the impact on the vehicle. But she was like answering questions appropriately. So she moved to the people laying in the street, or the kids laying in the street. She had some fire that had already responded. So she took a firefighter to each one of them, did a quick assessment, gets through and says just like, hey, keep an eye on them. Tell me if anything changes. She gets through all 3 of them. All 3 of them don't look good. 2 of them with bad head injuries. 1 of them who's kind of responding a little bit more. And then somebody starts yelling, he's not breathing. So she goes back over, gives a quick look, no breathing, doesn't do pulse check or any of that silly stuff, no breathing. And she's like, I mean, it's a kid, just start doing CPR. So chest compression started by the firefighter on that one, and then she hears it from another one. So she goes back to that kid, quick assessment, to start doing CPR. So they had already, because they knew that there were that many patients, they had dispatched, I think, at least 4 units. We had fire on the way. And because of the location, we were in North Houston, our trauma center is all the way on South Houston, or the south side of Houston, which is a massive city. You generally have to fly pediatric trauma. And so they were already starting to work on getting air. And they basically had already committed to saying, like, we're going to need at least one, if not more. And then I got in the vehicle, unfortunately, with the mindset that I was going to help to decide which kids went and which ones we were going to call on the field. Right? It's the hardest thing. It's the hardest thing to do. But at the end of the day, every air transport carries risk, right? Like we both know air has its risks, even if it's in the the most opportune environment. And this was at night in Houston, which is hazy and hot. And so it was not an opportune environment. It was not optimal to have, and now at least 4 patients that we were going to have to evacuate. So we have 2 that the out of hospital, the return, the ROSC rate on pediatric patients dying from trauma is it's like less than 1%. And so unless it's only airway, if it's a purely airway arrest, yes, you can get them back. But in these traumas, we have to assume hemorrhagic and everything else. So I race down there. I get there. It is a disco ball of lights. It's hard to figure out where I'm going. I see the first box and I head to that. I happened to get into one of the ones that was doing CPR. The medic had already done a crike on the kid. Kid's face was unfortunately, just destroyed, bad head injury. But the crike was good. And they still hadn't got ROSC yet. So I just really quickly, I was like, I looked at everything. I was like, just start blood for right now. I'll be right back. And they were like, we don't have blood yet. It's like, okay, well, I need to let me get you blood, right? Like we need that, right? If we're going to do this and I'm going to call these, I want to make sure we check all of my boxes out here. So go to get blood, have to get it from one of the supervisors. I catch him, thankfully, and I was like, grab all of the blood. Anybody who has blood here, get it, right? Bring it all here, and we're going to start divvying it up, right? Because now we have to start to triage our treatments before we have air. Air is about 20 minutes out. So, and we only have 2 helipads for 4 patients. So we had to do cycles, right? So we had to figure out who was going to go. We had to control. There's nobody there. We don't have like ground air traffic control. So, they're going to have to offset these aircraft. Somebody's going to have to control this whole thing. So I stopped by the incident commander, who was one of the assistant chief firefighters. And I was like, hey, listen, like, if you're not already tracking on this, that, like, I heard there's only 2 pads that they can use, or 2 landing zones, like both of them were parking lots. I was like, we're going to need 4 helicopters at some point. So you're going to have to offset that. And so just make sure you keep communicating that we're going to need them, but that there's going to be 4 helicopters in the area so that they all are aware, right? But you have to let them know too. Military coming back. So
Dude, I'm engrossed right now. I am like totally into this.
So I was like, where's the other cardiac arrest? So I get to the other cardiac arrest, and try and get a quick report on them. No, not as significant of a head injury, had a good airway, but they just weren't getting ROSC. So I get blood real quick. I help blood get blood set up for them, because at that point they were just given like fluid and epi. And I was like, this is not what we need blood if we're going to have any chance at getting oxygen so that we can restart everything, right? So get blood going, running it through the IO, give what I think is a reasonable bolus for the kid's size, and then we somehow get ROSC. It could have been a combination of a bunch of things, but we get ROSC, and it was amazing, because it was like, everybody had been kind of working on this kid for almost 15 minutes, and we managed to get ROSC. So luckily my air crew shows up. I give like a quick report of what I knew about the patient, and then talk to them about what their plan was for transport, make sure everything's good, and then go back to my other cardiac arrest and tell them, like, hey, if you're on with your guys, let them know we have another cardiac arrest. I'm going to do what I can. Otherwise, they're going to take the kid from the front seat, because she has 2 femur fractures. So
Holy smoke.
yeah. So I know, and a kid, like I think she was 8. So I get to my other cardiac arrest, and as I walk in, I really give it a better look, and I see the kid's chest, and they're bagging through the crike, and everything should be good. Sats are kind of like in the 80s. No major hemorrhage that I could see, and I look at the chest, and one side just isn't moving. Right, like it's just one of those things. And I mean, they'd been doing CPR, right, on a small kid, so one side's not moving. So I look at the medic and I was like, what's the problem? And she was like, we can't, like, she's like, I don't know why. She's like, we've actually had PEA most of the time. And I was like, so what's the problem? I was like, you have something obstructing. And I knew she had just done the critical care course, and she looked at me, she goes, you want me to cut the chest, don't you? And I was like, I do. Or no, she said, we need to cut the chest. And I said, yes, we do. And you're going to do it. And she was like, first time doing it, it's going to be on a kid, right? Like we had done it on ribs, right? So we just used pig ribs that I picked up at the store to train on, right? So I taught them how to do it, like how I do it safely, right? Cut down to the rib, use the rib as your backbone, feel the rib, use everything to push through. Don't go diving in, have everything. So we walked through it really quickly. I was like, you remember everything we talked about? She was like, yeah, we just did it. I can do it. Okay, I'm right here, but you're going to do it. And so I walk her, I watch her. She did it perfect. She vents the chest expands, and we get RosQ. So it was like, man, like I'm cheating today. Like I'm cheating. Like this shouldn't happen, right? Like you don't get these days, right? Like, and that's what I told him after we get that kid back. Everything's good. The air crew shows up and they're like, you're not doing CPR, seriously? And so, 2 RosQs on scene. Then we start triaging. Then we make sure then before they take off, each one of them, because I wanted to make sure those medics were comfortable with pain management during the thing. I went around and talked to them about just, what their dosing for fentanyl was going to be, or what their dosing for ketamine was going to be, just to make sure that I was checked with them, so that I knew that, they were still my patients in a way, that they knew they had a good plan for what they were going to do en route, so that these kids didn't freak out and become uncomfortable and everything else. And so we get everything set, we get them all off. We actually were lucky. They kind of kept the scene just blocked off for us for a while, and we debriefed right there, right in the middle of everything, because it's super intense. And so we debriefed. We had 2 supervisors, and we had the one medic, or actually, no, I should say all except for one medic truck that took one of the patients by ground, because they pulled off the 4th helicopter for a gunshot. So that's the way it goes in Houston. But we, with the initial responding medic and everybody who managed the cardiac arrest, we actually got like a good 15-20 minutes to just hang out, debrief, take some of those deep breaths, because everybody had to go back to work after this. And so, we get through everything, did our debrief. We ended up debriefing with, it was great. Like within 2 days, we set up a debrief to include all of the local emergency responders. So fire, police, and our EMS and our dispatch center. And then we also looped in the pediatric trauma surgeon and the ER docs who were down there. So we had and nurses. So we had this huge debrief, and it was great, because when I did my part, I was like, listen, like we didn't do anything magical. Like thankfully these kids are resilient, and they do come back. But ultimately, unfortunately, it wasn't great outcomes. Both had devastating head injuries, and that's the way that it goes. But we were able to give the family the opportunity to say goodbye. And I think that's the most, right. In these circumstances, was at least that happened. So, so many learning points from that, right? Like, just as simple as like the ABCs, right? Like all I did was think simple. They're given epi, they're getting stuck because they're not just reevaluating the ABCs and coming in with fresh eyes. It was easy for me, right? Like I could just come in with fresh eyes and say, well, you crushed the crike, it's perfect, but what's wrong with the breathing, right?
Yeah.
That chest isn't moving, and you have PEA, right? So why do you have PEA? There's some sort of obstruction. It's probably not post, it's probably preload. So why do you have a preload obstruction? I was like, look at the chest. And then once they figured it out, you know, like it was like, okay, and they'll never forget it, right? And then with circulation, it was like, you know, we're getting all these weird rhythms. We don't know why, like, you know, we're back and forth. It's never asystole, it's just bouncing all over the place, but we don't have a pulse. The pulse ox isn't really reading unless we're doing compressions. Like, we don't know what's going on. And I was like, you don't have volume, you don't have the right volume, right?
Yeah.
You need
the tank is
blood
empty.
in now. Yep. The tank is empty, and just putting fluid in, I mean, it's not solving the problem, right? Like, blood is the answer. So once we got blood going, got blood in the kid, we got ResQ. And so, you know, amazing to have that happen, right? To have that, to have us be able to save the kids. I mean, devastating that, you know, they didn't make it, and the whole thing is in itself is devastating. But learning points that I think everybody took away, you know, and I mean, just the triage piece, you know, like, it was amazing to watch from that body cam, see her go through and make decisions, who was getting in the truck first, what they were doing, you know, that kind of stuff. I mean, and a very young medic. And so, you know, again, one of those great things where it's like, you know, just literally days before, having taught her on a slab of ribs that could have been turned into barbecue, and instead was practice for us, you know, was what kept that kid alive, so that their family could see him off.
Wow.
So yeah, definitely a crazy call.
Holy smoke, that is wow. So like I was like deeply like into that story. So wow. Holy cow. Real quick, I do have to help everybody else that doesn't totally know. ResQ is return of spontaneous circulation. So that means that they get a pulse back, and they have that pulse, and now we're looking at whether they're breathing on their own or not. So whether we need to assess breathing. So ResQ is that's what that, I need to throw that in there. Now, out of curiosity, like, did you do a chest tube or just needle decompression?
No. We did a instrument thoracostomy.
Oh, okay.
So So we vented, we cut the chest, essentially. We made a hole that could take a tube, but a chest tube is not technically a pre-hospital procedure unless you're qualified and trained to do it. And I mean, evidenced by me having done, I wouldn't even be able to count how many times I've done just done instrument. I say instrument thoracostomy because most of the time I'm doing these on adults, and I don't know them before I start to stick my finger into their chest, and I don't trust that they don't have broken ribs that are going to give me something that they may or may not have, because they're not going to admit to it when I decide to stick my finger into their chest, right? So if I just go blindly sticking my finger into their chest and they have broken ribs, and I cut my finger and I now have acquired whatever they have, that's on me, right? So it's instrument thoracostomy. And then if by my instrument, I can feel the ribs and I can feel that there's no major fractures and shards, then I will stick my finger in there just to confirm that I'm in place. But I can do that with with whatever curved utensil I have, or the other end of a scalpel, if that's the last thing that I do. But, you know, like, if you know, as long as it's a good safety blade, I've used the blunt end of my scalpel to do that also, because, like I said, I don't trust that whatever they tell me, because most of the time they can't tell me anything beforehand. You know, they do and don't have, or they do and didn't, you know, acquire something from in the last couple of months.
Right. Yeah. Better to be safe. You stay on the safe side. That's
Exactly.
Yeah.
Do it right. Yeah.
Holy cow, Chris. Oh my gosh. That is insane. I do love the idea of the blood, bringing in blood and filling a tank. Like, and I say fill a tank, replenish the body with the fluid, with blood. You know, we talk about this a little bit, but, you know, blood in itself is what's carrying the oxygen to everything. When you put your saline or your ringers, that's not carrying the oxygen. That's just giving you volume. So that awesome.
And it's got everything, right? Like, we use whole blood in the US now. We're trying to use whole blood instead of components, right? So instead of using red blood cells and plasma, which are usually what you see in the pre-hospital environment right now, because that's the easier way to store it, we're using whole blood. So at that time I was giving him whole blood. I was giving the patient whole blood. And so we're giving them not only the red blood cells, we're giving them the plasma, which contains all the coagulation factors, which contains a replenishment of some of the electrolytes that they do need, right? I mean, you suck up calcium no matter what when you get blood, but there is some calcium still in, residual in there. And so you're giving all the thing and that somebody needs in order to correct the entire cascade of their hypovolemic shock, right? Or of their massive hemorrhage. It's not just giving, yes, we're giving them oxygen carrying capacity, but we're giving them everything that they need to start to correct, right? So whole blood is the way of the future. It's also the way of the past. It's what we were doing back in World War II, actually World War I believe we were doing that. So whole blood transfusions have been around for a long time. And then it became easier, or it became theorized to be easier to do component storage. And so then we went to components, and then now we're going back. Now the whole flop is going back. So we had some great presentations about that in the conference. And it's definitely some really interesting topics to look forward to in the future. So.
Hey, they don't call it the practice of medicine for nothing. I'm just gonna.
It's true. True. Yep.
Dang, man. All right, Chris. You got. I'm in for the long haul. So.
Yeah.
You sent me another one where you were on an airplane, and that was all good and all bad at the same time. So.
Yeah. I mean. So for anybody who works in aviation, we at some point are going to be around incidents, and unfortunately I've been involved in or part of or had to respond to numerous. And it's a tough thing to work through for anybody in that environment. But I thought this was a cool case just because I remember that picture of the crash up in, I think it was northern Scotland, where they had the medic still with the patient, even though the helicopter had crashed, right? So that's us, right? And so my story is I was flying. So this was my one of my Afghanistan deployments. I was going to pick up a guy who had been shot across the pelvis, and so had bad vascular injuries, had been getting a ton of blood, and so go and pick him up. Actually went into the OR, helped with fasciotomies, and I mean it was crazy. The whole thing started out crazy. It was a dusty, sandy, windy day, and you might know what those feel like, because I definitely do around here. And so we get the patient out. I am struggling with this guy because he had been massively transfused. They were running at that point. We weren't using whole blood, so they were running out of components. They were given a lot of packed cells without a lot of plasma, so he was kind of leaky. We were doing everything we could, but I mean the guy he was coagulopathic and he's just leaking everywhere. So we get him on board. I made the call at one point. I was just me and the trauma surgeon looked at each other and I was like, we've got to go because you've got nothing else. So these are the things that I think I need, and let's get him bundled up and get him out to the aircraft as quick as we can. So we do that. We're en route. I'm doing everything I can. I give him all the blood that we had left. We're kind of, I didn't want to put him on pressors because they had done some vascular repair and that can really screw that up. So I'm just trying to keep the guy in a comfortable, where I'm comfortable, even though it's not good. I have to be comfortable enough that when we're flying and when we're landing, that the physiology doesn't change so much that I lose him. Right. So I had luckily had done enough. I did almost 300 transports. So I was pretty close to knowing what I needed and what I didn't. And so we are, I would always be up on comms with the aircrew because I wanted to make sure that they were knowing what was going on with my patients, so that they could help to communicate reports if I wasn't able to get them out through our channels. And it also, sometimes they're willing to accept certain risks if I push them to, right? So all of my decisions, everything I ask them to do, is in ways asking them to accept risk, right? I need you to fly faster, or I need you to fly lower because my patient has a head injury, or I need you to do, like, some of those things that we had to ask them to do were risk, and they had to decide. Ultimately, they're the aircraft commander, not me. And so I could tell them what my patient needed and what I thought they could do to help. And if they could do it, they would do it if they're willing to accept the risk, right? So I would always be on comms so I could communicate that to them. So I'm up on comms, and I would also know when we were getting close and when we were, like, close to landing, and how far out we were from touching down. And these are military aircraft, so it's not like you're smooth, like just glide in and land real nicely. And you have to do things, and so it's never fun right at the end, and everybody has to kind of hold on. And so we were ready for that in a way, but we hadn't like all positioned ourselves appropriately. I hear the 500, so we get calls for distance, right? Because the back enders will let the pilots know what their altitude is, so that way there's a cross check with their instruments. And what they're seeing, so that there's like everybody's kind of on the same page. So if anything malfunctions, you've got redundancy of people confirming where you're at, right? So I hear 500, I hear 250, I hear 100, I hear 50, and then I just feel bam, like and 150 seemed a little bit close. 50 and the slam, I don't know exactly how long it was, but it was not long. And so the theory is that a shear wind took out our lift and we just dropped. Luckily, we dropped onto the flight line. But in a C-130, that's a lot of weight dropping. So we hit. My nurse had been crouching, and so she was crouching. We hit. She goes down. Her butt and tailbone slam into a hard, because we did patient care on the floor also. So I luckily was kneeling. And so I was able to take I was more springy. She slammed into the floor. And so she's like laying on her back and can't move. The other medics, or the other medic, he was luckily just about to get into a seat. So he got thrown into the seat. He was okay, but not quite ready, with it. And then I look at my patient, and I see like where I had, constantly been watching his vascular repairs across his pelvis was just oozing, saturated. And so, shook him up enough to probably some of the shunts that they had put in probably tore. So I throw both my knees into his pelvis, and just kneel on the patient. I get up on comms and check that everybody else on the aircraft is okay. Luckily nobody was injured, but I hear them saying like the ground crew is on their way out. They're going to check the plane, but they have to stop. So we're in the middle of this huge flight line in the middle of Afghanistan, and I was like, if the ground crew is coming out, I need an ambulance now. Like get me transport to the hospital now. So ground crew gets out, find out that the actual tail of the aircraft had cracked right underneath us. So the tail was cracked, so we couldn't move anymore. And they couldn't put the back down, so we had to go out the side door, which was a pain. So
side door of a C-130s are ridiculous.
Yep.
It's like it's not that wide. For anybody that doesn't know a C-130 door, it's like maybe 4 feet wide. It's not wide.
Right. So a patient on a NATO litter with vents and everything else going, man, and trying to keep them from bleeding everywhere. Like, it was a mess. So
sorry, I didn't mean to cut you off there. I get it. I know the C-130 well.
That's what you have to do, right? Like, I mean, unfortunately, it teaches us to, you have to make decisions and you have to do things not in the ideal way. And I think like that's what keeps me coming back to rescue, right? Like search and rescue is like, you can think that you're doing it 100% right. You're never that. Like you definitely don't know rescue if you think you're 100% right at any point, right? Like you're just willing to accept doing things in ways that are close enough, right? Like we said before, like close to right, head towards right, and you're good, right? Yeah. So same kind of thing. Like going out this door was not the right thing because with the angle, everything, like it was going to be really difficult, unsafe for us moving him. Like there was just so many problems. But I was like, we got to move. So I'm making the call. We're going out the side because they can't do anything else right now. Like we're going out the side. So we actually got him into the hospital. I think as far as I know, he survived through the hospital that we were delivering to. I don't know beyond that. But then of course, like, we crashed. So as a flight doc, because I was also a flight doc, I got to help with the investigation because the flight doc who was there had never done one. And he had never been involved in it. So I kind of had to walk him through everything that needed to happen. So me and my crew are like going through all the like after crash investigation stuff. And I'm also having to do that. And then as soon as I was done, they were like, "Hey Doc, you ready? Because we got more to go." And it's like, I just got home, man. Like, can I have a day off? No.
Can I get one day? Just one. That's all I'm asking. Can you throw me a bone, please, for a minute? Yeah. So thank you, U.S. military. Huh?
That's right. Yeah. And that's, I mean, but I think like the reason that this is one of those cool stories is, fortunately, like, we weren't bad off, but we weren't well off from this. You don't walk away from a crash feeling like, oh, that went great. Right.
Yeah.
But you have to keep your head about you. And the most important person, unfortunately, in that circumstance is the patient, right? Like, that's what we're there to do. And people will forget about that. And so, yeah, ground crew's on the way. I don't care about ground crew, man. Get me an ambulance. Right. Yeah. And so, and luckily, I mean, my air crew were awesome. They knew what our mission was and they were doing it already. But in some circumstances, you might not have pilots who routinely do medical evacuation. And so in that case, you have to be that advocate. You have to push to get your patient out there. So, yeah, so it was something that definitely still sticks with me, because luckily this time we all walked away from it and we got the patient back, or we safely delivered our patient. So we accomplished our mission. That aircraft, last I heard, is still there. May or may not be. I don't know what condition it's in now.
I was gonna ask.
It didn't leave. It couldn't leave. And so I don't know what condition it's now. I'm sure it's torn up or blown up. So, that's a sad. It is. That's the sad reality there.
Wow.
So, yeah.
I've been in some hard landings at a C-130, but I can honestly say I've never been in one that cracked the entire tail. Yeah, that's a little bit much.
Yep.
So, wow. Dang. And the rest of the crew, everybody other than any.
Yeah, thankfully, the nurse, she just needed a couple of days, bruised tailbone, but thankfully she was fine. No major injuries. And then all the rest of the air crew, they were back on as soon as they had a new aircraft. So
wow.
Yeah.
Awesome. Well, that's good to hear. Dang, man. Chris, holy shit. Wow.
Yeah.
All
Fun stories, man.
Well, I'll tell you what, let's change gears a little bit. I want to get into some training because you and I talked a little bit, and you as a medical director have been put in charge of a lot. And some of the trainings that you've run through, you mentioned doing some down in like Arizona and whatnot. So, and like we talked about a little bit, like an entire bus going into the Grand Canyon, like you went extreme. So bring us into a little of that. Like you as a medical, are you setting all these trainings up? Is it your idea, or are you collaborating with a bunch of people?
So the way that, I think search and rescue is a perfect example of the way that you drive all of the air crew continuity and skill and everything by just adding certain complicators to the patient scenario, right? Like search and rescue doesn't go out to just like, they do fly around, fly grid, and do the actual search portion, but the real tasking is for the rescue, right? And so I learned pretty quickly, or I just understood that by me being involved in the beginning, right? Like what were the pilots trying to achieve out of their training, and what were their training objectives or their learning objectives? Like if they want to do a high angle hoist mission or winch, some people call it winch. I with hoist. if they want to do a high angle hoist mission, or they want to fly, you know, some crazy route, or if they want to have their patient laying in this, you know, like really difficult to get to area, or they want the patient status to change during the flight so that the pilots have to make a decision, right? Like I can drive all that through a patient scenario while also accomplishing learning objectives for my medics, right? So so I got training to me is, I mean, you know, it's the key. The good quality training is the key to good quality performance. So I got into doing that, you know, on a regular basis, and we talked about like some of my theories and how I would stress people, right? And I mean, if I can do it to pilots, I'd do it to them too. And so
we already do that.
Yeah, yeah. There's so I got involved. We had this. We hosted this exercise every 18 months in Arizona, Angel Thunder. It's now I believe moved to Las Vegas area under a slightly different name. But at the time, it was it was constantly growing. I think I told you over the course of I did it twice as the medical director and the lead medical planner. I think over the course of it, we had almost 30 countries participate. We had 2,000 we had 2,000 participants, from air crew to ground coordination to full hospitals set up all across the southwest US. We did all kinds of scenarios. You know, individual. We did single person, and we did earthquake scenarios with, you know, over 400 patients in the Phoenix Scottsdale area. In northern Arizona, we did 400 patients that were isolated because of earthquake, and, you know, overloaded hospitals with that. We did water rescue off of San Diego during great white breeding season. That was not my idea, but we pushed for it. And then one of our technical guys wanted to do a hoist mission in the Grand Canyon. So we got approval to do it. So they wanted a scenario that would challenge people. And obviously, like, one person stuck on the side of the Grand Canyon, that's boring, right? So we did the school bus.
We didn't put the school bus over. Sick, like.
Yeah, it was crazy. We brought the school bus in. We had it kind of like made up to look like it had tipped, and then we simulated, I think, 6 or 7 patients over the edge, with another 20 up on the edge, like on the edge of the Grand Canyon. And so they had 6 rescues to coordinate along the edge, and then we had multiple up on. So that way, really, it was to get, like, there were a lot of people who needed to do the actual hoist technical piece, and so that was the way that we did it, right? Like they're like, I have 6 guys who I needed to do high angle technical rescue, and so let's, you know, we need 6 of them. Great, I can do that. A school bus. So but you can't make it easy, right? Like, you don't just get to show up and fly around in the Grand Canyon. That's just nice. So we made them deal with another 20 patients while they were also, like, doing these rescues, right? So the team had to make decisions. The pilots had to figure out the evacuation plans. And ultimately, how am I going to tell them they did or didn't do it right? Like, I don't evaluate the pilots. I don't evaluate the hoist. I don't evaluate the technical, like any of the technical aspects of the rescue. My job is the medical piece. And I can't just hang out on the side of the Grand Canyon and be like, oh yeah, you definitely missed your assessment of the pulses or something like that. No, right? So the way that I did this, and for 400 patients, how am I going to know that for 400 patients, they at least did something medically appropriate for each one of those patients, right? Because I had the patients, like, drive them to do something. So each patient had, depending on the severity of their injuries, they had 1 to 3 key interventions, right? And so there were 3 things in serious patients that needed to happen in order for me to say that they did an adequate job, right? And they weren't like anything complex, but like if it's an extremity hemorrhage, they had to have a tourniquet. If it was somebody with a non-extremity but in hypovolemic shock with some abdominal or chest injury, they had to get TXA. If it was a head injury, they had to make sure they documented a good blood pressure and a good pulse ox, right? Like certain, like, simple things, but the things that would make the difference in life or death, really. So each one of those patients patients on the side of the Grand Canyon. They had like one intervention that needed to happen medically. And I told everybody before going out, I was like, listen, if your patient is a patient, then you have to treat them like a patient. If they say, I'm perfectly fine, I don't have any injuries, and you want to just say like, hey, I'm just going to do a quick exam and you check them out and they're good, then they're good. But if they're a patient and they say something hurts, or if something's bleeding and they're moulaged, or if they're not participating and they can't tell you anything and they're like acting altered, you got to figure it out, right? So you don't get to just play, right? This is not just a game. So yeah, so that's what we did. We set up that scenario. It was awesome. I didn't get to go because I was running 9 million things, and I was in charge of not only the scenario development and the medical, like the actual evaluation of the performance. I was also in charge of all the backside medical directions. So if anybody got hurt or injured, I was up on that. I was the one who was like coordinating all of our medical assets across whatever 3-4 states we were in. And so I really, unfortunately, was stuck in an ops center. I didn't get to go out and play in the field very often. But it's one of those like just crazy times where you really see how you can make things real, right? Like you're getting excited because this is real. It's not like me saying like, oh, hey, you have a person laying over there and it looks like their leg is broken. Go, right? Like that's boring. Right? Like, no, like right. You have a person on the side of the Grand Canyon and their wrist is broken and they've got a big bump on their head and they're trying to like grab you, right? Like they're trying to pull you down. What are you going to do? Right? Like, how do you safe that scenario? Right? So go.
Yeah. Right. I'm gonna bet the medic's gonna win that one. I'm just gonna throw that out there. I would win.
Oh yeah. Every time.
Yeah, I don't know about every time, but I'm going to try like hell.
Yeah.
Man, that is awesome. I love it. All right, so let me go a little bit deeper with this. You being the medical director side of things, because in cases and calls that I've been on, and it can be something simple. Like I don't want to call you. Like protocols are written, you approve them as the medical director, and I'm going to follow them. I guess the question now is, what happens when I need a little bit more? Or because I fly, I'm out of radio contact with my medical director and I can't call for medical direction. Where is it? How do I want to ask this? The best way for me to move forward, I guess, is kind of where I'm going with this. Like I don't want to go against protocol, but at the same side, like let's say I max out my fentanyl or I max out my ketamine, depending on the drug I'm using at the time. And I'm like, I just need a little bit more. We've got another 2 hours to go. I'm out of radio range. Is this something you would be okay? I push a little more. I do a little of this. And I write it up when I get back and call doc. So this is what I did. I'm sorry. But like, what's your take on that? Again, as the medical director, you're trusting your guys in the field. Okay, I've talked too much. Your turn.
There it is. So you got to the last word, right? Trust. Trusting your medics as a medical director is important, right? And that comes from that high quality training environment, and working closely with them, right? Like understanding the environment that they work in is important. I was not a paramedic before I became a doctor, right? And in some ways, some people look at that as like, you won't be a good med director because you don't know what it was like. Right. I was fortunate, I think, to train in New York where I was by myself all the time with patients. And then to be put in the position of being a search and rescue doc where I was flying missions by myself. So I learned it. Not everybody gets that opportunity, right? So you have to trust, your doc has to trust you and you have to trust your doc that in that weird environment, they're going to be able to understand what's going on, right? And so that's what makes a good medical director. And I think, not to say that you have to be EMS trained, but I think that's one of the things that we really, really focus on when training our, docs. Now that it's a formal board certified specialty in the US, it's important, right? I mean, and the UK has it too, and then there's some certifications in Australia. So there's some ways to get that training, and what it really comes down to is trusting your medics to the point that you know their protocols, and you know that they know their protocols and they know how to work, but you also know them personally, so that if they make a decision, what you were talking about, right? Like I'm out of radio contact. The time is too long. I need this to do this. It's what my patient needs. I feel it's safe at this point. I know the risks and I'm going to monitor for them, right? So your documentation just needs to reflect that, right? You did break protocol, but you broke protocol with the understanding that you were still working within a reasonable, like close to right of your protocol, right? Like you're allowed to
right.
You're
On the way to right.
You're allowed to do these things. Yeah. You're allowed to do these things, right? Like if you think that everything pre-hospital needs, like I've said it, right? Like nothing pre-hospital is ever going to be 100% right. So you can't 100% be held to your protocols. If you're doing what's best for your patient, you're doing it safely, and you document your reasoning for it. And then the last thing was like, right, like when you get back and you say, hey doc, like this is what happened, right? So that was the best thing for me in Afghanistan and Iraq when I was there, was like my guys would get back from a mission and they didn't do anything wrong, but they'd be like, hey, like this is what we did, this is what we did, this is what we did. And then I would help them to reason through it. I would help them to find, the way that I would put it is like, I'm going to give you the doctor words for what you did, right? Like I'm going to explain to you the decisions that you were making, because I can understand it now because I'm thinking clearly and you're telling it to me, but I can help you to make logical sense of all this, so that the next time you're in this position, you know why you were making these decisions, right? And it helps you to make them either faster or more comfortably the next time. It helps with your documentation. And if anybody comes after you, this is the hardest part, right? Like you show up to a hospital and let's say they actually know what's going on, right? Especially with ketamine, depending on where you're working, right? And you have given your patient a good amount of ketamine and they're slugged down. And they ask you like, why did you do this to your patient? Like, what's wrong with you? Right? Like they shouldn't be like this. They don't understand. That's the first problem. The second problem is you now need to not defend yourself, because don't ever feel like you have to defend what you do pre-hospital. You're doing what's best for the patient, right? So that's your answer. You're doing what's best for the patient. So if you call me, because you can, and you say, hey doc, this is what's going on. My patient's still in pain. I want to give him this, or I've given him this much whatever antibiotic and he's starting to turn red, and I think I need to give these things, but if I give him all these medications, like if I give him Benadryl and I have a steroid, if I give him all these things, is that going to mess up whatever else is going on, right? Like if you're not sure and you have that comfort level with your doc, you just say like, this is what I think is best right now, right? Like this is me on like looking at the patient. This is what I think is best. What do you think, right? And that's and I do that in the hospital all the time. I include everybody in decision making when it comes, even in the most critical situations. Like when I'm running a code or when I'm running a trauma and they're sick, I still will find times I'll take those tactical pauses and I will pull everybody in and I'll say, this is what I think we need to do. Does anybody else have anything else? Like, does anybody else see something that I'm missing, right? Or does this sound good, right? So bring people in, make those decisions. If you have another medic, talk it through. Here's the risk. Here's the benefit. I think we can safely like get across this bridge. And then we'll talk to doc after we've turned over the patient, after we've calmed down, and we'll talk to doc as soon as we get comms up, right? So like those are don't surprise your doc with that. Don't like blindside them with I did some crazy procedure, or right. If you're not credentialed to put a chest tube in and you stick an ET tube in somebody's chest, please tell your doc right away, like, I did this because I thought I should, right? And this is my reasoning, and this was what I had to do. And it was 2 hours. And if I kept sticking my finger in their chest, I just felt like it was going to cause an infection. So I thought that this would be the best answer. So this is how I did it. And this is what I did. And I've experienced it in some other environments. And so this is, you know what I mean? Like, I've had that happen to me, right? Like that has happened to me as a medical director. I've had a medic come in and be like, I stuck a tube into somebody's chest. And I'm like, all right, slow down. Let's talk all the way through this. Like, that's the end.
Let's start from the beginning. You did.
Let's start from the beginning, right? Yeah. Like fasciotomies, right? Like fasciotomies for prolonged field care for medics, you don't want to have to do that ever, right? And remembering where to do them is really hard. And if you don't have your references and you don't know where to do them, right? Like doing a fasciotomy is a big deal, but we train our medics to do that. And so when I had a medic do a fasciotomy, like he came in like, the dog that had chewed up the sofa, right? Like tail between his legs. And this is a big dude. This is a big boy. He was a Marshall from like Montana, big boy,
Okay.
and smart too. Like went to a like a super good university, Brown University in the U.S. So like super smart, big dude, just tail between the legs, and was like, "Doc, I don't know, man. Like, I might have screwed up. All right, sit down. Let's start. Right? Like, where did it start? Like, tell me the story. And like, I knew the call, but I didn't know what happened. Right? And then, okay, walk me through how your fasciotomies looked. Like, what were you cutting for? Okay, so that makes sense, right? So document all that stuff, right? Write it down this way. I made these decisions because of this, not because somebody on the ground said, "Oh, you might need to do fasciotomies," right? Like, he was like, "That's what put it in my mind," and I was like, "No, that's not what put it in your mind. You were managing a patient en route who was in it, like he lost sense and pulses in his foot, and you needed to do something, and his leg felt tight, and you knew that he had a fracture, and you were transporting for more than a half hour, and he had already been down for over 2 or 3 hours, and you knew where to do the cut, so you made a cut, so you did it." Right. And you thought it was what was best for your patient. And ultimately, like, it went okay. Nothing happened. Like, nothing, it didn't fall off. His leg didn't fall off after you did it. So, at the end of the day, like, you did the best that you could because you thought it was what was best for your patient. So,
Yeah.
So that's my take on it. Right. Like, I mean, just have that relationship with your medical director. I think it's like vitally important to have that, that trust, that mutual trust. And if you don't, man, like it's rough.
Yeah.
It's really rough. And so, I don't know how to tell you to work in that environment, because that's not me. I don't like to put medics in that position, right? Like, you have to do it the way that I told you, and that's your only option. I'm wrong, right? I'm wrong if I say that. So,
well, and I mean, I'm going to preface like with the final as nobody start breaking protocol. Okay. This protocol means that don't be breaking protocol because of this conversation. That's not what we're saying. All right.
Nope.
Follow your protocols. There's that little bit of gray area.
The rare exception where you don't go crazy.
Yeah.
Right.
Yeah.
You didn't turn into a trauma surgeon and start doing crazy things, right? Like, you are working as close as you can to your protocol, but you feel that you need to just slightly adjust, not break, adjust, add, or continue, like extend your protocol in a way that is safe for your patient, right? And when you say it that way, you can't like break that down in a way that makes it that you were doing something you went off the rails, right? Like, you did not. You were staying within your protocol, and you knew your protocol so well that you knew you were at the end of it, and you knew that it needed a little bit more, and that little bit more was safe, and you knew how to monitor, and you at the end of the day knew what, like, when to make the decision, when to make that time sensitive critical decision to do that. And then at the end of it, you acknowledged that you did it, right? That's the last thing. If you do that and you don't acknowledge it, then you're asking for trouble, right? Then you're asking for trouble. That was the best part about that medic coming to me, right? Like, he could have not told me, because we took that patient to a hospital I would have never heard from. So he could have dropped that guy off and never said a thing, and I would have not probably heard about it. But he came to me because he knew that he did something, and he wanted to understand why he did it, so that he could document it, so that it was something that he had owned up to, right? Like, he had done something that was within protocol to an extent, but I mean, time sensitive, he could have waited maybe, but he felt like it needed to be done. And so I backed him up. Right. And so when the question came, I backed him up, and there was no problems. Right. But that's what needs to happen is you have to acknowledge it. You have to document. Otherwise, now you're hiding. Right. And when you're hiding it, then that's like saying I did something wrong. Right. So
own it. Own it.
Yep, exactly.
Admit it. Own it. Yeah. Man, this is awesome. Chris, this has been amazing. I appreciate all this good stuff. And like, I like to think that I had, like, while I was in, so it was interesting, like, we're talking about the doctor and medic, or EMT basic for me in the Coast Guard, my relationship with my docs, like, there was a doc at one unit that I was close with, but the guys that are on call, one of them was in Hawaii. I didn't know him from Adam. So that's an interesting dynamic. It just so happens that doc is on call that day. He's taking medical calls for the entire West Coast, but at the same time, I worked down in the Gulf of Mexico, and the docs came and flew with us from time to time. We would bounce into the hospital just to hang out with them. And, hey, what do you got today, doc? Oh yeah, come check this out. And we'd be in, like the student, hanging out with the docs. So yeah, go get with your medical directors, hang out with them, get that personal relationship there so that, I'm all about it. So
absolutely. Yeah.
Chris, this has been unreal. Thank you so much for coming on and sharing this side of like the doctor world, the medical director side. Again, you're the first guy on that I've had on that can give us this aspect. So I appreciate it. So thank you.
Yeah, absolutely. I appreciate it. Last thing I want to say is, like, it's you heard stories that I give where I get to not take credit. I get to feel what you get to feel. And so build that relationship with your medical director and build that relationship with your mission, right? I mean, like if you are a search and rescue, if you're HEMS, if you're EMS, if you're whatever you are, if you aspire to do those things, right? Like connect yourself to being the person who goes to help somebody on the worst day of their life. Don't ever hold that against them in the way that they respond to you. Don't ever hold that against you for the way that you come out of that mission. Because if you show up every time thinking, I'm going to do what I think is close to right for this person, I'm going to be the best person I can be, I'm going to be the best medic I can be, man, like, I mean, it's honestly one of the most honorable and amazing things that we get to do. And so thank all of you for doing it. Thank you, Jason, for bringing me onto this. I mean, it's definitely, it's been awesome. As you can tell, I love talking about this stuff because it brings me back, right? Like it just brings me back. I told you, I'm in for life, but like every time I get excited, I'm like, all right, when's my next one? Right. So it's great. And they're terrible things that happen and we get to be the ones to turn them around. And so thank everybody for doing that. Thank you all. It's an honor to be, thought to be included on this because, I get to support what you do. So,
man, I love it. I'm cutting it with that. And with that, ladies and gentlemen, we are out of here. Go. Thank you for tuning in. We hope you enjoyed this episode of the Real ResQ podcast. Please take a minute to like, subscribe, and hit that share button. I'm pulling chocks and taking off. But before I go, if anyone out there has a rescue story they would be willing to share, I would be humbled and honored to have you on as a guest. Or if you have any questions about rescue or anything else we talk about here, send an email to jason@therealresq.com. That's Jason at TheRealResQ.com. You can also check us out on our web pages, therealresq.com, our Facebook page, and our Instagram page @TheRealResQ. Again, a special thank you to all of you staying on the watch today. Always remember, when that SAR alarm goes off, those in distress are praying for a miracle. They are going to get you. Until next time, fly safe and swim hard.